colon. Oh, the here देखा recurrent angina के लोग वैसा elaborate करो. देखा? What are the surrounding structures that can be damaged? One is hemorrhage. Hemorrhage can be primary or secondary. Primary or reactionary or secondary. Primary can before the patient leaves the theatre. Reactionary will again from that point up to 48 hours due to ligages or dislodged clots. Right. Moral patient repair during the surgery from where? From the gland, from the upper pedicle, from the superior pedicle, superior thyroid artery treatment, inferior thyroid. What are the surrounding structures that are at risk of getting damaged? Thyroid taking restricted. Trachea, esophagus, especially when you are operating on massive coitus, esophagus से हमारा एडिलेना और thyroid उधर जाना पड़ता है. Carotid sheath, so those are the structures that are risk of getting damaged. Especially when you are operating on the extra retrosternal extensions, you can damage brachiocephalic vein, even the subclavian vessels. Those are the risk of injuries. What are the other complications? Okay, laryngeal. Any other complication? Okay. What is the risk of recurrent laryngeal injury? It's about less than 1%. In hemithyroidectomy, what is the risk of hypocalcemia following? That's another complication. Hypocalcemia following surgery. Temporary about 70%. About 30%. About 30%. Permanent? About 8 to 10%. Permanent means you have damaged all 4 glands. How do you know what does it look like, parathyroid? Have you seen parathyroid? What does it look like? Is it big one or small? Very small. Very small. What is the color?
Brown.
Brownish yellow. Brownish yellow. And you easily confusable. You tap karo, they are pratu part. Easily confusable. Because you have to move the very confusable. If you remove it, accidentally remove it. All what you differentiate whether it's fat or the gland. How do you differentiate that? You put it on saline. If it floats, it's fat. If it sinks, it's gland. Gland. You just chop it into small dices. And then you inject it into the sternocleidomastoid. Or make a small pocket in the sternocleidomastoid and put it in and put a stitch. It takes about 3 months for action to start. Like apohydrophila, it has to gain blood vascularity from the muscle itself and then you take some time. That is called autotransplantation. Autotransplantation. So, Sanu, you are the house officer. Your SR has done the total thyroidectomy. Patient comes to the ward. What will you do as a house officer when the patient comes to the ward? Okay, check patient. Go to the patient and check patient. These are common vital questions. I will go to the patient and check the vital parameters. Check the pulse rate and talk to the patient and see whether there is any hoarseness or stridor. And also check the blood pressure and other parameters. Okay. And I will keep the patient propped up. Like surgeries may have to lie on to keep the patient propped up. Then you got it. ඊට පස්සේ ගිහලා රජෙක් කැන්ටින් එකේ කනවා. පාලනකොට දැන් community को लोग बहुत सारे हैं। Now you are also community की लाइन मार रहे हैं। कितना लाइन हुआ बता रहे हैं मैं मार कर गया। वह जानो यहाँ मैं लगे पैदा मैं मस्ती ले दूँगा। एक को वाला उतर कर आने आता है उतर कर फिर काफी है। खाने लगी आइसक्रीम खाना all what we check at the exam is whether you are suitable to become my household. If I feel that you are suitable to my household, I will pass. If I am at a risk of getting you as my household, is that? No, I will have to suffer again to learn. That is the only thing that we check. This is what they check. Okay. Yeah, what she said was absolutely true. Attend to the patient, check the vitals, talk to the patient. The patient may not be completely recovered from general anesthesia, but you talk to the patient. Talk about the patient. Plastic color bar.
Take the anesthetic note, post-op management. Anesthetic note, post-op.
Yes, very good. Go through the PHPNs, go through the op note, and go through the anesthetic note. Are there any special interactions? Was it routine thyroidectomy, or were there any injuries that the surgeon or the anesthetist note has to monitor? So go through the op note, go through the anesthetic note, just to see whether there are non-routine steps to be done. Any patient we nurses monitor. Right? Are there specific instructions given? So go through the op note, go to the anesthetic chart, look for any specific instruction. Were there any non-routine steps? Were there any inadvertent damages or something to worry about? Very good. Then check the patient, monitor the patient other parameters. So, while they are on the ward, patient develops stridor. Have you heard stridor? Right? Right. Hoarseness problem. Nama they hoarseness. They hoarseness. That is hoarseness. Okay? Stridor is something very high pitch. Stridor means upper airway obstruction. What is the lower obstruction part? Upper airway obstruction is stridor. So what we do? We are also Malawi. Just know what you do. If you are line or whole leg not up the oh, man, also no, you just go and attend to the patient. Just check patient, vital, talk to the patient, reassure the patient. So the patient, patient struggle karna, suffocating. So to talk to the patient, reassure the patient, check vitals, attach the patient to a cardiac, basic thing. I will immediately attend to the patient. I will immediately attend to the patient, check patient's pulse rate and talk to the patient, try to reassure the patient. If the patient is not already propped up, I will prop up the patient. and then I will get the nurses to give oxygen via face mask and arrange adrenaline nebulization. Right? Adrenaline nebulization. At the same time, I will get additional IVFs to the patient. Okay. You check saturation. Saturation is around 98, but patient is struggling. There is a strike. Saturation 92. What are the causes of strike? I told you it's a very theoretical hypocalcemic tetany of the vocal cords. Agree, but it takes some time. So, उत्तर देता मैं अंतिम उत्तर देता laryngeal edema, very common due to handling of the gland, especially when you remove large gland. You turn the gland this way, turn the gland that way. We struggle to remove large glands. So there is a possibility of laryngeal edema because of the excessive handling. That's one reason. Anything else? How does hematoma cause thyroid?
You obstruct the veins.
Any other reason?
Obstruct the venous return.
Any other reason? Huh? No, I am asking how can hematoma cause thyroid? Huh? Obstruction. How? Any other reason? Any other reason? Or is it the only reason?
Irritating. Irritating.
No, that's the only reason. I want you to get compression. Someone get compression. It's not the hematoma compressing the larynx. You just squeeze Charlie's neck and see how much of effort that you will put to again. You are tag hand matter. Stridor in a make. What's the bell being no together? You think hematoma can apply that much of pressure? No. It's a hematoma deep to the deep fascia. Hematoma deep to the investing layer of deep fascia, which can cause compression of the venous drainage and laryngeal edema. That is why even if it bleed, it takes some time. But after let our water to our stridor getting or the bleed it compresses the venous drainage and laryngeal edema, then stridor. Laryngeal edema due to handling, laryngeal edema due to venous drainage, blocked venous drainage by hematoma deep to the deep fascia, ectopic ulcers, and what else? Recurrent laryngeal nerve damage, rare, tracheomalacia, rare, and hypocalcemic tetany of the vocal cords may not be evident initially, but sometime later. So those are the 5 causes for stridor. As a house officer, if the patient develops stridor, you have to immediately attend and do those things. So then check what else you should do. The patient name is stridor, saturation 92. What else you should do? After nebulization and oxygen. Yes, you don't have to run to the phone, you get someone to call. Then I will inform seniors. So, attendant miss emergency again, phone. So you can get someone to call. So if you want, so you get somebody to inform your seniors while you stay with the patient. That's what should happen. Then, okay, you remove the plaster and see whether there is any evidence of hematoma. Generally, when there is hematoma, it is deep to the deep fascia. So you will sometimes see obliteration of this angles of mandible and see swollen neck. Then what you can do? Then what else you can do? How to relieve pressure? From that point onwards, it is not advisable for house officer to. You have to get your seniors. Too. And if the patient's saturation is further dropping, you have to get rid of intubation, right? Rather than trying to remove stitches, because just because you remove skin stitches, it will not to the needful. So you have to remove the deep fascia, investing layer stitches. So I'm sure house officer, it's difficult for house officer. So you can, if the patient saturates further, get intubate. Here, the most important thing is, it's important to know what was the size of the tube that was inserted during GE. Because if it is 7 French tube, you have to get ready with 7 and 6.5 and 6. Because to start when you start the surgery, it's normal larynx. Now this patient has thyroid due to laryngeal edema. You think you can put the same size? Very unlikely. And you think it will be easy intubation? No. Right? So inform your seniors, maybe get the help of anesthetic team and prepare the patient for intubation if the saturation is further dropping. The aim there is not to cause hypoxic brain damage. So you intubate the patient, get ready with the stuff. Anesthetic cell tube tubes ready. If it is, let's say, start anything you, as a life-saving measure, you can try to remove stitches. So basically, you reassure the patient, talk to the patient, give oxygen, nebulize, prop up, inform your seniors, and then get ready with intubation if necessary, and prepare the patient for urgent exploration at the theatre. At the same time, you get someone to write a quick theatre list and inform the theatre and the anesthetist over the phone and send it to. Because rest of the things should happen in the theatre. You have to remove all the stitches, achieve hemostasis, and then close it. If you think it is due to. So those are things that they ask at the exam. Okay. Any questions? Any question about thyroid?
So like if partial cut of both pical and venous is complete obstruction happens from the workup?
Partial cut of bilateral partial damage, complete obstruction. The rheumatoid will completely close.
So what we are doing in that case? If that happens in the surgery?
So at the time of surgery.
Or
It doesn't happen. To see.
no, if it happens, what's the
Fracture shock. Fracture shock. No other. Or else coming completely. So at the rheumatoid will be like this. It's a between. Don't do that. Mostly it is neuropraxia. Mostly neuropraxia, it will settle after some time. Unless there's a malignancy with infiltration of the nerve already. Mostly it is neuropraxia due to handling of the nerve. Have you seen it on the nerve? It's a white color flat nerve with a blood vessel on it. We call it toothpaste sign. Signal toothpaste again. Two part goes another part left hand. Like toothpaste. Any questions about thyroid? The thyroid can typically active now and some more time. Now then we need to go and read it and do MCQ.